Good afternoon and good evening to one and all who are watching the Sankara Academy of Vision YouTube channel. Today, we have with us Dr. Gangadhar Sundar. It gives me great privilege to give the introduction to Dr. Gangadhar Sundar, who's been my teacher and has influenced the way what I am today, actually. And Dr. Gangadhar Sundar obtained his degree from the Madras Medical College, Chennai, in India, and he received his advanced subspecialty training from the Henry Ford Hospital in Detroit, in USA. And after working for a short stint at the Sankara Eye Hospital, Shankar Netralaya in Chennai, Dr. Gangadhar Sundar moved to the Singapore National Eye Center and the National University Hospital in Singapore. And Sir is currently the consultant at the University Hospital and specializes in orbit and oculoplasty and trauma and ocular trauma per se. So without much delay, I'd like to invite Dr. Gangadhar Sundar, who will be talking on a very important topic for all of us, addressing that it's just not ophthalmic trauma. It's just not ocular trauma that we should be worried about, but also ophthalmic trauma. So let's do more about it. Over to you, sir.
Thank you, Girish. I suppose my screen is visible.
Yes, sir.
Really am humbled by this invitation by Sankara Eye Foundation, which is taking up a major cause in this important day of World Sight Day. I bring you greetings from Singapore on behalf of our Department of Ophthalmology, Orbit and Ocular Facial Services, and the various societies I represent, of which Asia Pacific Ophthalmic Trauma Society has taken the major cause in ophthalmic trauma. I wish you all well and hope that we can prevent blindness from this most preventable cause of blindness, which is ophthalmic trauma, and labeled it as not just ocular trauma. Let's do more. Today is World Sight Day, and I think it's important to put into context that we not only cure blindness, but it is imperative that we should be able to deliver vision to every single person needy for the 7 billion around the world, and most importantly, be able to prevent it. And rightfully speaking, we have to make sure that we have, and unfortunately not yet achieved, but ensure that we are able to provide eye care for all and also prevent blindness in most of our patients. And I'd like to felicitate Dr. Ramani and Dr. Radha for having had the vision way back more than 30 years ago to really initiate the cause of trying to deliver better eye care for our patients, not just from the south of India, Coimbatore, which is famous for its various subspecialty medical hospitals, but all over India. And rightfully, they've been recognized and honored by various leaders, by the nation, and hopefully due recognition from around the world. And proud to say that both Dr. Sapta Girish and Dr. Shruti, with whom I worked very closely over the years, are doing a wonderful job in the field of orbit and oculoplastic surgery. I represent National University Hospital here in Singapore. We are a tertiary care level 1 trauma center. And despite the fact that you're a developed country, we still see a lot of injuries in and around the eyes, the face, and the rest of the body as well. We do see both trauma and other pathologies from pediatric, adult, and geriatric services as well. And what has really propelled our cause forward is a close collaboration that we have with our other specialties. Some disclosures: I do serve as a faculty, but there's no conflict of interest in anything that I mentioned here, and some authorship on trauma and oncology-related books. We are all familiar with ocular trauma, and we talk about globe injuries itself. We are kind of familiar with an incidence spectrum and outcomes, and we'll touch upon that. But I'm going to emphasize a little bit more about ocular adnexal trauma, highlight a little bit about ophthalmic trauma societies around the world, showcase to the ophthalmologists and the non-ophthalmologists the injuries extend beyond the eyeball to the eyelids, the lacrimal duct, and the orbit and the face, and what else or what more we can do as professionals. When we talk about trauma, typically we talk about mechanical trauma, but we oftentimes forget that chemical injuries, thermal injuries, electrical injuries, and ultraviolet injuries, and not to forget, as physicians, sometimes we introduce iatrogenic injuries which cause mutilating damage to the eyeball and even the vision. And this is important to be kept in mind. When you look at mechanical trauma itself, the leading cause has always been road traffic accidents, regardless of whether, again, you are from developed or developing nations. But thankfully, in the developed nations where strict laws are enforced, protective eyewear, including headgears, are enforced, we are able to prevent a lot of these specific structural injuries itself. Again, where regulations are not really enforced, industrial and occupational injuries are quite common. And be surprised to know that, especially in a country like India, industrial accidents are still one of the leading causes of preventable blindness. Then, of course, come assaults, which happens in all societies, falls, especially in elderly, and now with young people, especially in the COVID era, taking up new sports who are not physically fit, end up having sports injuries. If you look at the Indian statistics itself, it's alarming to note that 2.4% prevalence of various forms of globe injuries, ocular trauma. This is from a major urban setting in North India. And the average age is about 24 years. That's very young adults. Typically, they are males more than females, and an alarming number more happens at the workplace. There's a good mix of both blunt and penetrating injuries. What is shocking to hear is that about 11.4% of these various ocular trauma end up in significant blindness in that particular eye. And these are some of the references both from the Indian subcontinent and Southeast Asia, where we studied our data on ocular trauma itself. And the consequence of any trauma, as we think about it, is only from a visual point of view, a functional point of view. We don't realize that it has significant structural disfiguration, which is a pathology, which in turn leads to psychological and social consequences, not just to the individual, but to the family, the society, the nation as a whole, and finally, all of this affects the world itself. So what really causes eye injuries at work? 60% of them is from not wearing protective eyewear. And unfortunately, remaining 40% of them from wearing the wrong kind of eye protection. In other words, simple spectacles, thinking a foreign body entering from the side of the eye will be prevented from entering the eye, but unfortunately, it's not true. And sad to note that 90% of these injuries can easily be prevented by proper use of eye and facial protection. These are some points to ponder for the ophthalmologist, which is more common: globe injuries or adnexal injuries. Which structure is really stronger, the eyeball, the globe, or the orbital walls? We'd like to think the bones are strong, but not really true. And which can be rehabilitated better, the corneoscleral lacerations or ocular adnexal injuries? So here's a spectrum of various forms of ocular injuries or closed injuries, which can be classified into closed globe injuries and open globe injuries. And we now know that open globe injuries, especially if not attended to early, can result in very poor visual prognosis. And while on one end, we see things like corneal scarring, hyphema, cataracts, all of which can be beautifully rehabilitated by the state-of-art techniques and technology by developed ophthalmologists. When you have optic nerve injury or open globe injuries with infections or poor healing with phthisis, or in children who have bad injuries with amblyopia, these are causing irreversible blindness, which is what is the goal of prevention of ophthalmic trauma rather than management. One of the major advances in ocular trauma was the use of ocular trauma terminology, and unfortunately, still around the world. This is proposed by Professor Ferenc Kohn, who's the president of the International Society of Ocular Trauma, with which we APOTS are closely associated, introduced a standard of terminologies which is still not yet being used, and which I think should be really used. Because if we don't use appropriate terminology, you won't be able to classify the various injuries and thus manage them and communicate with your colleagues. He also introduced the concept of the ocular trauma score, which I think is imperative to calculate the severity of the injury and thus prognosticate to ensure that we are able to deliver good results, not just give up on any injury with an eye where we say that guarded visual prognosis. What are the determinants of good visual outcome is the nature of injury. Blunt injury is usually much worse than penetrating injuries. The severity injury is determined by the zone of injuries from the front to the back, any pre-existing ocular morbidity, the timing and intervention, which is where institutions like Sankara Eye Hospital is very important to ensure that trauma is immediately attended to day or night and a 24-hour service is introduced. The expertise of intervention is also extremely important because you don't want to leave it to the junior most people, but the experienced person be doing these good repairs, showing good examples, and then holding the hands of the younger people to ensure the first time is the best time towards good reconstruction and minimize the need for secondary procedures. However, when you look at the ocular trauma score in the Birmingham eye trauma terminology, the limitations are, number one, it is not specific. It is just for adults, not for children. Doesn't talk about other forms of globe injuries, including globe subluxations and avulsions, and does not differentiate between early and late presentation. That's where ocular adnexal trauma comes in. So what are the adnexal structures? The adnexal structures are the eyelids, which protect the eye, is the eyelids which kind of protect from thermal injuries, mechanical injuries by reflex mechanisms itself, visual, mechanical, or otherwise. Then the lacrimal system injuries, because if you don't manage an NLD fracture very well leads to acute or chronic dacryocystitis, which causes significant morbidity, including endophthalmitis and corneal ulcerations. And most importantly, orbital fractures, which is where we as oculoplastic surgeons come in. So the adnexa should be absolutely addressed at the same time you do at ocular or globe injuries. And this is where the close collaboration between the ophthalmologist, who's only familiar with the globe, with the oculoplastic surgeon, and these two teams with the craniomaxillofacial or head and neck trauma team becomes very important. Here are examples of patients who have had eyelid injuries in this young child or this young adult, which looks like a simple laceration, but if you look at it, it's quite a bad injury, sparing the globe itself. But if managed meticulously well, you can beautifully restore good aesthesis, function, and protection of the eyes itself. Here are examples of simple and complex eyelid injuries where, if managed very well, you can have good outcomes, as you can see in the middle left. Whereas if you manage badly, you can see very poor outcome with injuries to the corneal surface. And as you can see in the picture down below, with poorly placed sutures and sutures against the conjunctival surface, causing severe corneal aberrations, scratches, secondary infections, which can even result in blindness. Here's an example of a patient who was told to have just a forehead laceration. But we opened up the wound, you realize that it not only is masking a skull injury, even an intracranial injury. So don't trivialize any laceration on the face. What about lacrimal injuries? These are quite common both in children and adults, from avulsion injuries, dog bites, animal bites, and even human bites itself. The principles of management, again, within 24, 48, 72 hours, you want to adequately manage them with mono or bicanalical intubation. And if you have nasolacrimal duct obstructions, and if you don't manage them prophylactically, in this case, as you can see, with prophylactic lacrimal intubation, you will end up with various forms of dacryocystitis, which will cause a lot of facial infections, intracranial infections, and orbital infections. The third part of the ocular adnexa injuries that you should be aware of are orbital injuries. Historically, in the past, this was managed by facial plastic surgeons and craniomaxillofacial surgeons, but this is where the oculoplastic now surgeon comes in and taking the lead, because he or she is the one who knows the globe very well, puts the globe in structural anatomical context to the orbit, which in turn has structural anatomical context to the facial skeleton, by rehabilitating the patient the best that he or she can. So they can be classified into contusions and fractures. We have introduced our own practical classification and principles of management in the book we talk about, we mentioned earlier on. So is it ocular injury or is it orbital injury? This case example shows you a beautiful case of an expulsive wound of the eye, where you can see on the top left, contents more or less exposed. And the patient was repaired with a globe injury, and only postoperatively, when they did a scan, found that the foreign body had entered through the front and the back of the eye into the orbit. So hence is a combination of both a globe and orbital injury. So you do not want to repair these globes with penetrating injuries without imaging the orbit and addressing the foreign body as well. Here's an example of a young physician who had a rocket-propelled grenade blast injury to the midface. You can see the mangled eye in the bottom left, and you can see the disfiguration with bone in smithereens, where when you repair it primarily the first time, one of the very few cases we do a primary globe removal, which you try not to do unless it's completely mangled up, you can try to restore structure, function, and symmetry in one go without patient living with disfiguration for the rest of his life. So what are the spectrum of fractures that we see? These are typically caused by various incidents. We talked about road traffic accidents. We talked about industrial accidents. We talked about falls, especially in the elderly population. But with more and more people taking up sports, either for physical fitness or because they have more free time during the COVID era, we are seeing a lot of sports-related injuries. And especially in unregulated environments or unsupervised environments, in a country like India, where kids are playing with these bows and arrows made out of sticks, and some of us are guilty of doing this when we are children ourselves, with the absence of protective eyewear, we end up causing a lot of injuries. So here's a spectrum of injuries that sports which cause various forms of orbital fractures. And it used to be thought that only contact sports led to a lot of fractures, but even things like cheerleading, basketball in the North America continent, for example, surfing, all these are notorious for causing injuries of the orbit and the face. And we as oculoplastic surgeons believe that an orbit, when broken, can be fixed, whereas an eyeball, when broken, can be fixed, but the function cannot always be restored depending on how bad the injury is. So in summary, We talked about ocular trauma. So what is really ophthalmic trauma? Ophthalmic trauma is a consummation of both the globe injuries, whether it's closed or open globe injuries, with optic nerve and the various cranial nerve injuries, including the structure behind the orbit, the brain, traumatic brain injuries, and eyelid, lacrimal, and orbito-facial injuries. And this is where an ophthalmologist is complete only if he or she is aware of assessing and properly managing, and if he or she cannot manage it themselves, ensure they work with colleagues who can ensure that we develop a holistic care in this most preventable type of blindness. So what can we do and what more can we do? We can do a lot more. And that's where we as a profession, in a way, have failed, because we are wonderful in managing injuries, but not necessarily in completely rehabilitating, and even more importantly, in preventing these injuries. So the individual practitioner can do things, small group practices can do things, and large institutions, including Sankara Eye Foundation with its leading group of hospitals, and other hospitals, as you can see in Tamil Nadu and the rest of the country, where they can do a major job in taking the cause forward in preventing blindness from preventable eye injuries. What can training institutions do? They can introduce fellowship training in ophthalmic trauma and developing specific trauma units and teams. Ensure that there is interest kindled in the younger people, with people built with passion, not from economic remuneration. Again, Sankara Eye Foundation has been a role model in ensuring that it's a commitment and service which is more important than remuneration, with the right balance, so that the physicians working in those teams, whom I know very well, are extremely passionate and motivated in delivering the best care to these people. It is not just individuals, but several individuals coming together as teams. And the teams can be both within ophthalmology and other disciplines, including craniomaxillofacial trauma. So pure ophthalmic institutions can link up with other institutions who see a lot of head and neck injuries and offer their ophthalmic services, not sit in their own cubby hole and being secure managing globe injuries themselves and referring everything else out. There should be proper prioritization of these patients with appropriate triage, both in major trauma centers and ophthalmic units. And emergency evaluation should be done upon immediate news about a patient with potential eye injury or orbital injuries, followed up with early and urgent repair, rather than leaving it to the next day or a few days after that. Expertise also should be emphasized, because while the junior is most available, should be held hands by the senior most people. Okay, and that is important to ensure that we get good outcomes. What can ophthalmic societies do? That's where All India Ophthalmic Society, Ocular Trauma Society of India, Tamil Nadu Society, and the various city ophthalmic societies can do more. They can start developing curriculums with sub-assessment and certification with periodic outcomes. It's not a matter of just putting it all together, but making sure that the patient-reported outcomes are as good as what the surgeon thinks he or she has done a good job. I'm proud to say that the Asia Pacific Ophthalmic Trauma Society, which was founded in 2011, with members from more than 20 countries, has taken a major lead in educational conferences and webinars and symposia in conferences around the world, both within India, Southeast Asia, within APAO conferences, with the European Society, and also the American Academy of Ophthalmology, which has for the first time brought together ophthalmologists from the front to the back, pole to pole, as I would call it, at Nexel specialists, oculoplastic surgeons, neuro-ophthalmologists, neurologists, allied health, including optometry and ocularis, so that we are able to comprehensively rehabilitate these patients. Education is very important. That's where we mentioned earlier on about the various city and state societies, where we should educate not just ophthalmologists, but we should probably educate non-ophthalmologist specialists as well to recognize eye injuries, recognize orbital injuries, so that they're able to reach out to a competent ophthalmologist or orbital surgeon who can work with them. And just as how we do major public education with cataracts, glaucoma, diabetes, so on and so forth, I think these societies have to take it forward to ensure, reach out to schools, colleges, industries, factories, so on and so forth, that good eye protection is taught, practiced, ensured, so that we work towards preventing injuries rather than managing these injuries. Hence, public forums and various dramatic images, as you can see over here, showing disfigured eyes, disfigured faces, and showing that these can be one of your family members, one of your neighbors, who could have easily had their eye injury prevented rather than be managed by the top-notch ophthalmologist in that particular city or society. Public education packaging is also very important because we talked about sports and toys, which do cause a lot of injuries, just as how we do for cigarettes. I think it's important that we work industry, and this Shankara Eye Foundation's celebrations on World Sight Day, having thought leaders from industries come in so they can now take the lead and work with us ophthalmologists to identify which are the typical activities that cause various forms of ophthalmic injuries, take it to the industry, take it to the factories, take it to where the packaging is being done, so that we are able to educate both children and adults who buy these various hardware devices, toy devices, and tell them that these simple toys and devices themselves can cause blindness, so that they take extra precaution and, if necessary, wear eye protection. It is also important that we as ophthalmologists, when we prescribe glasses, pay attention to the nature of material that makes these optical lenses. It is important that both one-eye patients and children get polycarbonate lenses, not just any cheap plastic or glass lenses, which themselves can break and poke the eye and cause open globe injuries. Hence, preventive ophthalmology is what we should be practicing in terms of ophthalmic trauma, not therapeutic ophthalmology. Emphasize various specific, industry-specific protective eyewear, whether spectacles, goggles with side shields, windshields, or face shields, so that we can prevent these injuries. What can other physicians do, non-ophthalmologists? First, training primary care physicians to recognize, offer first aid, wear protection, including eye shields, to make sure that further injury is avoided. And non-ophthalmologists should be taught about damage control ophthalmology, an evolving field which is typically practiced in army areas where specialists are not available. Likewise, craniomaxillofacial surgeons, head and neck surgeons should have partnerships with ophthalmologists and oculoplastic surgeons. So we are available 24 hours to train and work with them to ensure that we do the best care possible in the first sitting itself. What can communities do? At the home environment, we can avoid dangerous behavior, adequate supervision of children. When people are practicing sports and other activities, including driving road traffic on the road, wear the protective spectacles, goggles, visors, and helmets. And the industry not just have regulations, but ensure that enforcement and prompt reinforcement with reward and punishment should be ensured. What can policy and governments do? Apart from having policy, have a legal framework so that people who fail in adequate protection of the employers and the employees are also taken to task, reprimanded, and rewarded at the same time. So with the positive reinforcement with the ministry's collaborations, we are ensuring that everybody from very high up to the top to the right to the person on the floor receives good eye protection. So in summary, what I try to emphasize is identify that globe and adnexal injuries are quite common. Ophthalmologists should take the lead along with our industry partners to ensure this proper communication both within the specialty and outside the specialty itself. When we met with the patient, we make sure that we have a comprehensive management of ophthalmic trauma victim. But most importantly, because this is the leading cause of preventive blindness, typically in children and young adults who have productivity for the next 20, 40, 50, 60, 70 years, ensure that we prevent them. But if an injury happens, make sure that the ophthalmologist collaborates with the adnexal surgeon, oculoplastic surgeon. The ophthalmologist collaborates with the head and neck and the craniomaxillofacial trauma teams. Physicians, apart from just being physicians, should become physician leaders. They should become the patient advocates, liaise between the patient, the family, industry, society, and policy makers. And I think this is the era of activism where we're taking up other silly causes. We can take up this cause with the right education at school, colleges, universities, and work environments. With enforcement, we can do more. Thank you very much. And I appreciate and congratulate Shankara Eye Foundations and Shankara Eye Hospitals for taking this lead on World Sight Day and take up the cause with other ophthalmic institutions in India and this part of the world and prevent ocular and adnexal trauma. Thank you very much.
Thank you very much, sir. It's been a wonderful talk, and I'm sure all the postgraduates and the residents who are going to watch this will really take a lot out of this. I just had one question, sir. You've been now in Singapore for quite some time now, and Singapore being a very, as far as putting in policies that they seem to be a little more faster. What has been your experience in the past few years that you've been there in seeing that any policy decisions as far as trauma prevention is being done there?
Right. I mean, being a developed country, they have rules, regulations, and what is special about a developed country like Singapore is enforcement. And there's periodical supervision of the various work sites. And years ago, whenever a preventable injury happened, these institutions were taken to task, or the supervisors were taken to task. And periodically, their results, whether good or bad, were published, made public. So there was both a positive and negative reinforcement. So over the years, we found out that occupational injuries, occupational deaths has significantly declined over the years. The unfortunate thing about trauma is that while almost always it's preventable, it's hard to achieve a zero, but that's a goal to which we should strive for. So no number is too small to say that we can be complacent, we have achieved our targets, but you want to achieve towards zero. The other important thing is while all these legislations are in place, supervision and certificate courses are being done, there's also the onus upon the citizen, in other words, the person working in the work environment, ensuring that they follow the instructions that are given. And we know that in developing nations, where people think in the name of personal freedom and rights, they think that they can get away with all the regulations that's given to us, which is what spreads a lot of pathology, including infectious diseases, as we can see in various parts of the world. So the right mix of education, reward, periodic admonishment, publishing statistics, showing cases of good examples and bad examples has dramatically reduced in Singapore. And I'm sure a great country like India and China, which are there at the leading parts of the world now, can now take this up as a cause where both ophthalmic institutions and industry partners can take this forward.
Thank you, sir. Thank you very much. Sir, on behalf of Sankara Hospitals and Sankara Academy of Vision, Dr. Shruti also joins me in thanking you very much for a wonderful talk, and we all will definitely benefit from this. Thank you, sir.
Thank you, Girish, and wish you all a wonderful World Sight Day. And I compliment again your institution, Sankara Hospitals, Dr. Ramani and his team, and all ophthalmic institutions in India, which have been doing a wonderful job. But let's take it further through our societies with our partner organizations. Thank you.
Thank you, sir.